Bismillah ar-Rahman ar-Rahim. I would like to welcome all the students who thankfully joined this lecture. And for optimum use of time, I kindly request you to keep your comments and questions after the presentation. If you have urgent comments, please raise hands, and we will announce the next topic after this presentation. Principles of pulmonary resection is the topic of our lecture today. And in this lecture, we would like to speak about the bronchopulmonary anatomy, history of pulmonary resection, the indications, types of pulmonary resections, preoperative evaluation of the patient, incisions, the principles of anesthesia, and surgical tips and techniques. Pulmonary resection is the operation that defines the thoracic surgeon. This is a very beautiful statement which indicates the importance of this operation. In other words, any thoracic surgeon should and must master the procedure of pulmonary resection. Anatomic resections of the lung, including pneumonectomy and lobectomy, are the standard operative techniques employed to treat both neoplastic and non-neoplastic diseases of the lung. And any surgeon who intends to operate on the pulmonary system must be keenly aware of the anatomy of the pulmonary vasculature, the bronchi, and the relationship between the two. There is no substitute for this degree of familiarity. Now, in the following slides, I'm going to emphasize some important anatomical facts which are pertinent to the procedure of pulmonary resection. This picture demonstrates the intestinal surface of the right lung. And as you can see, there are many features. The most important feature is the lung hilum, or the lung root. The lung root is formed by the bronchus, the pulmonary artery, the pulmonary veins, superior and inferior pulmonary veins, the bronchial arteries, the pulmonary plexuses of nerves, lymphatic vessels, bronchial lymph glands, and areolar tissue. All of these structures are enclosed by a reflection of the pleura. So if you look here, the hilum of the right lung is characterized by a bronchus located posteriorly, the pulmonary artery in front of the bronchus, and it divides into two divisions: the superior pulmonary vein located anteriorly, and the inferior pulmonary vein located postero-inferiorly. There is a reflection of the pleura called the inferior, or the inferior pulmonary ligament, which extends from the base of the inferior pulmonary vein. And this is an important structure during lung resection, whether lower lobectomy or pneumonectomy. We can see the anterior border of the lung, the inferior border of the lung, the diaphragmatic surface formed by or depression formed by the liver. And as you know, the right lung consists of three lobes: the right upper, right middle, and right lower lobe. And there are two fissures, the oblique fissure and the horizontal fissure, which separates the lung into three lobes. You can see here the groove for the superior vena cava, the groove for the brachiocephalic veins, the groove for the arch of the azygous vein, and also you can see the esophageal and tracheal impressions. If we go to the left lung, similarly, we can see the roots or the hilum of the lung of the left lung, which consists of a main stem bronchus, and above the bronchus is the pulmonary artery, the left main pulmonary artery, the superior pulmonary vein in front of the bronchus, and the inferior pulmonary vein postero-inferiorly. And again, we can see the pulmonary ligament. The left lung consists of two lobes, the left upper lobe and the left lower lobe, separated by the oblique fissure. And there is a cardiac impression produced by the heart. And there is an impression formed by the arch of the aorta and an impression or groove produced by the descending thoracic aorta. In this picture, you can see that the chest wall has been removed and the right lung is seen. In this picture, as you can see anteriorly, the upper and middle lobes form the majority of the lung, and on the left side, the left upper lobe forms the majority of the lung anteriorly. Laterally, we can see both upper and lower lobes on the left side and the three lobes on the right side. The relationship of the pulmonary artery to the bronchi is important. As you can see, the pulmonary trunk divides into the right and left pulmonary arteries. Now, the right pulmonary artery goes and located beneath the origin of the right upper lobe bronchus, while on the left side, it is above the left pulmonary artery, is located above the origin of the left upper lobe bronchus. Now, each lung consists of a number of segments. On the right side, the right lung consists of 10 segments, and on the left side, the left lung consists of 9 segments. The bronchopulmonary segment is the structural unit of the lung, which consists of a pyramidal piece of lung parenchyma. The base of the pyramid is located peripherally, while the apex of the pyramid is located towards the apex or the center or the hilum of the lung. And each lung segment is supplied by its own segmental bronchus and its own segmental artery, while the venous drainage is through intersegmental veins. And actually, each bronchopulmonary segment represents a surgical entity because it has its own segmental artery and bronchus, and because of the presence of intersegmental plane of cleavage that allows the surgeon to separate or remove one segment, one disease segment, and preserves the healthy lung. It's very important from a surgical point of view. This is the diagram of the bronchial tree. It's very important to understand the division of the trachea into right and left mediastinal bronchi, and the origin of the right upper lobe bronchus, which divides into the apical, posterior, and anterior segments, and the middle lobe that divides into lateral and medial segment, and the lower lobe, which divides into 5 segments, the superior segment and 4 basal segmental bronchi. On the left side, the distribution is a bit different. The left mediastinal bronchus is longer, and it divides into the upper bronchial and lower bronchial division. The upper bronchial division divides into the left upper lobe proper bronchus, which redivides into the apico-posterior and the anterior segmental bronchi, and then the lingular bronchus divides into the superior and inferior lingular segments. And the left lower lobe is similar to the right lower lobe, but there is one different point. The medial basal segment, that is segment number 7, is missing on the left side. Now, if the lung is removed from the right side, we'll see the right side of the mediastinum. Some people refer to the right side of the mediastinum as the blue side because it is dominated by the superior vena cava and the arch of the azygos vein. And if we look at the left side of the mediastinum after removing the lung, we'll see that it is dominated by the arch of the aorta, the descending thoracic aorta, and the common carotid and left subclavian artery. Therefore, some people refer to the left side of the mediastinum as the red side of the mediastinum. Now, when the heart is removed, in this picture, the heart has been removed, and you can see the pulmonary trunk dividing into the right pulmonary artery, which is longer than the left. And the right pulmonary artery divides into two divisions. One division goes inside the interlobar fissure, while the other division gives rise to the apical and anterior segmental arteries. On the left side, the left pulmonary artery doesn't divide into segments, but it gives segmental arteries as it goes inside the interlobar fissure. Again, you can see the superior and inferior pulmonary veins. On the right side, the middle lobe drains into the right or superior pulmonary vein. And in this picture, which is obtained a bit posterior, you can see the bronchi, and you can see the divisions of the right pulmonary artery, as we said, into two divisions and into segmental arteries. And you can see also the tributaries of the pulmonary, the superior and inferior pulmonary veins. And here you can see the relationships of the pulmonary vessels to the trachea at this level of the bifurcation. On the right side, we have the arch of the azygos vein, and on the left side, we have the arch of the aorta. And again, you can see posteriorly, the pulmonary artery on the right side is lower than the level of the right upper lobe bronchus, while on the left side, it is above the origin of the left upper lobe bronchus. Okay, so after this anatomical account, which I hope is helpful for you in understanding the procedure of pulmonary resection later, there are important landmarks in the history of the procedure. Although the 5 patients operated upon by Bloch in 1883 and Cronlin in 1884 and Rugi in 1885 died following attempted partial resection of their tuberculous lungs, Tafia successfully resected the apex of the right lung of a 25-year-old man in 1891. The use of the individual ligation technique as proposed by Blades and Kent made pulmonary resection a safe procedure in general. So initially, the pulmonary resection was performed by a mass ligation of the hilum, but this procedure is no more practiced because of its complications. Later on, surgeons performed lung resection by individual dissection of the structures making the hilum or the vessels and the bronchi relevant to each lobe or each segment. In 1933, both Graham and Reinhoff independently performed successful pneumonectomy using this technique. The following decades witnessed refinements of surgical techniques and anesthetic management in the field of thoracic surgery. The efforts of surgeons of the 1930s and 1940s culminated and ended in the perfection of pulmonary resectional techniques currently practiced. So almost the procedure performed nowadays is similar to the procedure performed in the 1940s. In Iraq, pulmonary resection started in the treatment of pulmonary tuberculosis in early 1950s. So we are we should credit our great pioneer surgeons who performed the procedure in the 1950s and who taught generations of surgeons to perform the procedure safely and efficiently later on. Now, what are the indications for pulmonary resection? There are many indications. Primary and secondary lung malignancies are one of the common indications. Benign tumors, suppurative conditions like bronchiectasis, lung abscess, and pulmonary TB. Parasitic infestations like pulmonary hiatus cyst. Fungal infections like aspergillosis. Pulmonary sequestration. Pulmonary arteriovenous fistula. Congenital lobar emphysema. Chest trauma. And remember, any pulmonary procedure can change into pulmonary resection. Therefore, every thoracic surgeon should master the procedure, because any pulmonary procedure, for one reason or another, especially when there's an injury to a pulmonary vessel which is uncontrolled, the surgeon may be obliged to do pulmonary resection. Now, what are the types of pulmonary resection? We have different types. Simple and radical pneumonectomy, simple and radical lobectomy, bilobectomy, extended pulmonary resection, segmentectomy, wedge resection, palliative resection, sleeve lobectomy. Okay, so we have different types of lung resection. Radical resection refers to lobectomy or pneumonectomy combined with in-block mediastinal lymphadenectomy. So if the mediastinal lymph nodes are not removed, then this is simple lobectomy or simple pneumonectomy. Bilobectomy is a procedure performed in the right lung only. It is principally or basically consists of a procedure in which we conserve either the upper or the lower lobe. So we may do either a right upper and middle lobectomy or right middle and lower lobectomy. Okay. What are the indications for bilobectomy? When a tumor extends across a lobar fissure, or when a tumor invades bronchus intermedius, or when there is an endobronchial tumor or an absent fissure. The term extended resection refers to a lobectomy or pneumonectomy combined with in-block resection of involved contagious structures like a chest wall involvement or diaphragmatic involvement. Sleeve lobectomy is a procedure in which a lobectomy is performed for a primary tumor that protrudes upon the lobar orifice and prevents complete resection with a free margin by standard lobectomy. So in this picture, you can see a demonstration or diagram of radical pneumonectomy, in which the right lung is removed along with the ipsilateral mediastinal lymph nodes in a block section of mediastinal lymph nodes. That's why it's called radical pneumonectomy. And please observe that the line of resection of the mainstem bronchus is flush with the carina. There is no bronchial stem. It's very important to avoid leaving a lengthy bronchial stem. Otherwise, secretions can stagnate and result in infection and dehiscence of the stem and development of bronchopleural fistula. Now, in this picture, you can see the procedure of segmentectomy, in which a segment has been or is going to be removed after dividing the bronchus, the segmental bronchus. And here you can see that the proximal stump of the segmental bronchus is sutured, as well as the segmental arteries, and the segment is deflated because the bronchus is clamped, and because of the presence of intersegmental plane of cleavage, it is possible to remove one segment and leave the remaining healthy lung parenchyma. Okay, now here you can see a demonstration of right upper lobe sleeve resection in a case of a tumor extending into the orifice of the right upper lobe. Therefore, a sleeve of the bronchus, of the mainstem bronchus, is removed, and the remaining mainstem bronchus on the right side is re-anastomosed with the bronchus intermedius. And by this procedure, the patient is saved from pneumonectomy. This is a demonstration of right upper pulmonary lobectomy. The fissure has been combed by stapler, and the lower bronchus has been stapled, as well as the segmental arteries. Okay. Every patient scheduled for lung resection should be properly evaluated. So thorough preoperative evaluation and preparation of the patient reduces the morbidity and mortality of thoracotomy and pulmonary resection. Pulmonary function test and analysis of arterial blood gases help determine the feasibility of pulmonary resection. Postoperative pulmonary function is estimated by calculating the preoperative function and the projected or expected resection of pulmonary parenchyma. Patients are excluded from surgical therapy if the estimated postoperative pulmonary function falls below the minimum acceptable values. Anesthesia for pulmonary resection. Although many resections can be performed with bilateral lung ventilation, careful hilar dissection is greatly facilitated by using unilateral lung ventilation. The advent or introduction of double lumen endotracheal tubes and bronchial blockers has made it possible to isolate the ipsilateral lung and has made it easier for surgeons to carry out complex hilar dissections with required accuracy. So using one lung ventilation gives us a better exposure and a safer opportunity or to do hilar dissection. And here, in patients with centrally located tumors, care must be taken with placement of the double lumen tube, because inadvertent trauma to an endobronchial tumor during the placement of a double lumen tube can lead to significant bleeding and may compromise the airway. Additionally, it is important to confirm the position of the double lumen tube by fiber optic bronchoscopy after positioning or placement or after putting the patient in the lateral decubitus position. And here you can see the equipments used to achieve one lung ventilation. The double lumen tube is the commonest one. That is the portable fiber optic bronchoscope used by the anesthesiologist to confirm the position of the double lumen tube. And this is a set of bronchial blocker, which is an alternative to a double lumen tube used to achieve one lung ventilation, especially in children and sometimes in adults. Okay, now let us speak a bit about the incisions used during or for lung resection. Posterolateral thoracotomy is the standard incision for anatomic pulmonary resections. However, safe and complete resections can also be performed through a variety of smaller incisions, such as the posterior and anterior muscle-sparing thoracotomies and the axillary thoracotomy. In most cases, the thoracic cavity is entered through the fifth intercostal space, and this affords excellent exposure of the hilar structures. If an anterior muscle-sparing thoracotomy is performed, then the entry is through the fourth intercostal space. Median sternotomy is very infrequently used to do lung resection of the upper lobes, because while for the lower lobes, the exposure is very difficult during or through a sternotomy. This picture demonstrates the position of the patient during posterolateral thoracotomy, and also shows the incision used to perform this procedure and the muscles which are divided. This is a muscle cutting incision. The latissimus dorsi and serratus anterior muscle are divided. The exposure achieved through posterolateral thoracotomy is very good. However, we have some disadvantages, like the impairment of the shoulder girdle movement and the post thoracotomy neuralgia. Well, please, I just want to tell you that if the time is over, we can start again joining a new session of Zoom meeting to complete the lecture, please. That is a picture showing the incision for posterior muscle-sparing thoracotomy. In muscle-sparing thoracotomy, subcutaneous flaps are created inferiorly and superiorly, and the superior border of the latissimus dorsi muscle is mobilized along its entire length, and both latissimus dorsi and serratus anterior can be preserved, and can be, and we can avoid a muscle cutting. That's why it's called muscle sparing thoracotomy. The techniques of pulmonary resection had dramatically changed from mass ligation of the pulmonary hilum previously to individual ligation of hilar structures, and recently to video-assisted thoracoscopic pulmonary resection. So there is an development of new procedure or new techniques. The old technique is mass ligation of the hilum. It's no more practiced, while the standard technique is the individual ligation of hilar structures, which can be performed either through an open thoracotomy or via thoracoscopy. However, the safe performance of lung resection requires a perfect knowledge of the hydroanatomy and a technique with which the surgeon is familiar. Now, when we read about the procedure of lung resection, we may hear or read the term or the statement, the vessels first technique and the bronchus first technique. So what do we mean by the vessels first technique? Traditionally, during a lobectomy, the arterial branches are divided first, followed by the venous branches. However, if conditions exist that limit the exposure, like a centrally placed tumor or significant inflammation and scarring, the surgeon should start with the structures that provide the most accessible targets. So here, and we have a pulmonary artery branches, pulmonary veins, and the bronchi. The surgeon starts by the pulmonary vessels, the pulmonary arteries and veins, and the bronchus is dealt with at the end. That's why it's called the vessels first technique. Now, the vessels, which one is before, the vein or the artery? Veins may be ligated first. The proponents of this approach, and to ligate the vein first, believe that it may limit the escape of circulating tumor cells. Although this possibility is very rare, the opponents of this procedure, the opponents of ligating the vein ligature first, claim that initial vein ligation may lead to venous congestion and retention of blood that is subsequently lost with the specimen. Okay, so some people advise to ligate the vein first, especially when the case is a case of tumor, while others they prefer ligating the pulmonary arterial branches first. What about the bronchus first technique? Now, alternative to the vessel first technique, the bronchus may be ligated first, such as in excessive bronchial secretions due to bronchitis, bronchopleural fistula, or lung abscess. So sometimes we deal with a patient with bronchitis, with excessive secretions, and therefore there is a fear that the secretions may cause hypoxia and cardiac arrest, and therefore the surgeon may decide to deal with the bronchus first. There are 3 points to be considered when we decide to use the technique of bronchus first. First of all, the patient should be placed in a prone position, and when the distal limb of the bronchus is divided, it should be over soon to prevent spillage of pus or mucus into the chest. And after division of the bronchus, the lobar bronchus, the lobe is much more mobile. Therefore, to prevent avulsion of the pulmonary artery branches, care should be taken not to employ excessive torsion or traction. It's very important. Now, pulmonary vessels, whether arteries or veins, are different from vessels elsewhere in the body. Therefore, there are specific tips that we should learn to master a safe pulmonary resection. The techniques used for dissection, ligation, and division of pulmonary arteries and their branches differ from those used for other vessels. Pulmonary vessels are low pressure, high flow, thin-walled, fragile structures. Accordingly, for rapid and safe dissection, a perivascular plane known as the plane of Leriche should be sought. This plane may be absent in the presence of long-standing granulomatous or tuberculous disease, or after major chemo or radiotherapy, or in cases of reoperation. So it's very important to do dissection to reach the perivascular plane, which enables us to safely isolate the pulmonary artery or pulmonary vein branches. In these situations, when we have scarring and difficulty in getting the isolation of the pulmonary vessel, what we have to do, we have to do a proximal control of the main pulmonary artery and the two pulmonary veins before the more peripheral arterial dissection. So that if we encounter an injury of the peripheral vessels, we can easily clamp the pulmonary artery proximally and minimize the bleeding. And before any pulmonary vessel is divided, it should be controlled either with two separate suture ligatures proximal to the line of division or with the vascular staples. And stapling devices are especially useful for larger vessels. And in cases of pneumonectomy, sometimes the surgeon may have to enter the pericardium to do intra-pericardial pneumonectomy in order to get a control of the pulmonary vessels if we have a centrally located tumor. So if we look at this picture, it shows us the tips of isolating the pulmonary vessels. The pulmonary vessels are dissected by using a sharp scissor and by a P-knot. After that, we can pass a ligature around it. And always remember that ligature is the least safe procedure of controlling a pulmonary artery or pulmonary vein because it's liable for slippage. Okay, so proximally, we have to put two ligatures or two suture ligatures, and the division should be done next to these two proximal ligatures. And here, as you can see, if we have a bifurcation, it is safer to perform the division before the bifurcation, because the presence of the bifurcation will minimize the possibility of slippage of the ligature. Of the pulmonary artery or of any of its branches involves the opening of the adventitia of the blood vessel, dissection of its lateral borders, and use of a Leahy clamp to complete the mobilization posteriorly. The main pulmonary artery is usually controlled with a vascular stapler, while the individual branches are doubly ligated with two zero silk ties and divided against a clamp applied as far back as possible within the parenchyma. And when one is using the ligature, it is important to leave a long enough stump as to prevent dislocation of the ties. It's very important to have enough stump to avoid slippage of the ligature. And in cases where dissection appears to be hazardous, like in scarring or redo operation or chemo radiotherapy, it is always wise to get proximal control of the main pulmonary artery in case an injury occurs. And pulmonary veins are handled in the same general way as the pulmonary artery. These principles will be better understood in the next lecture when we speak about specific types of pulmonary resections, when we go and speak about pulmonary lobectomies one after the other, and the upper lobe removal, middle lobectomy, lower lobectomy, etc. You are going to understand these tips in a better way. Now, what about the bronchial dissection? Like the pulmonary vessels, we have also certain important tips relevant to dissection and isolation, division and suture of the bronchi. Exposure of the bronchus should not involve stripping of the bronchial surface or adventitia. Aggressive dissection may compromise the vascular supply and lead to impaired healing and bronchial dehiscence. So we should not do extensive dissection of the bronchus, or otherwise this will damage the blood supply of the bronchus. Overlying nodal tissue should be cleared, and lymph nodes adherent to the bronchi should be removed, and major bronchial arteries should be clipped just proximal to the point of division. And bronchial closure has been greatly facilitated by the use of automatic staplers. The bronchi can be closed either by interrupted sutures or by using staplers. And when bronchial length is limited, sometimes we have a limited length of the bronchial stem, one may perform suture closure of the bronchial stem rather than attempt to use a stapler. And whenever there is a high risk of bronchial stem dehiscence, like after chemotherapy, radiotherapy, or chemoradiotherapy, or in patients for whom adjuvant therapy is planned, or after right pneumonectomy, in these situations, a vascularized rotational tissue flap, example from the pericardium, or the pericardial fat pad, or the intercostal muscles, or the pleura, should be used to reinforce the bronchial closure and minimize the possibility of dehiscence and development of a bronchopleural fistula. Now, in this slide, you can see different types of staplers used for the bronchi and for the pulmonary vessels. And of course, these staplers are disposable. They are used once for every patient. Here you can see a bronchus, which has been controlled by a clamp on the side of the lung, and on the other side it has been stapled by a stapler, and now it is divided by the knife. Here you can see pulmonary vessels have been divided by the staplers, and here you can see a wedge of the lung has been removed, and wedge resection using the technique of staplers. So in conclusion, the take-home messages of our lecture of today: pulmonary resection, as we said, is the operation that defines the thoracic surgeon. And if you think you are a thoracic surgeon, then you should ask yourself, are you able to perform different types of lung resection safely? This is an important question. There is no substitute to perfect knowledge of pulmonary, vascular, and bronchial anatomy beside a safe dissection skills. As you have seen, you have to have an imagination of the structures located within the interlobal fissure or within the hilum of the lung, and you should be aware of what is posterior, what is anterior. Otherwise, you may injure an important structure during your dissection. Efficient thoracic anesthesiologist is a must to perform a safe lung resection. So it's a team work. Both thoracotomy and thoracoscopy can be employed to perform lung resection. And specific types of lung resection will hopefully be covered and presented in the next lecture, inshallah. And I would like to thank you for your patience and watching this lecture. And I hope you enjoyed the lecture.
Thank you very much, sir. It was very nice topic for us.